Hi, so we are going to talk about Chapter 9, the general and special senses. For this chapter, I went ahead and I broke up the chapter into the general senses. So, just sensory in general, pain, and then I added in the olfactory and gustatory as well. And then I separated out the auditory and visual sections of this chapter for their own focus. So let's get started. Let's talk just in general about sensory. This is helping us to interact with the world around us, right? It's going to communicate to our brain information with the outside environment. So this starts with sensory receptors. In this image, we have free nerve endings, which are plentiful in, say, our extremities, our hands, for example. We have many free nerve endings that are helping us interact with the world around us. The other thing to take note of is the idea of the receptive fields. Note here we have one receptive field and two receptive fields, and they are each connected to a nerve ending or a branch of nerve endings that are going to converge and communicate that information back to the central nervous system. I do want to point out here that these receptive fields are communicating information in the areas that they are innervating. Why I point this out is the back of your hand, for example, is made of many receptive fields. They are numerous. We have a great number of nerve endings that are helping us interact with the world around us. However, if we compare that to the back has large receptive fields. Say, for example, we would combine receptive field 1 and 2, and that would innervate just one area, one nerve. And so the fun thing to try out when you are with a friend or a family member is to put two fingers, making a peace sign, put two fingers on their back. Oh, there are my balloons. Put two fingers on their back, just using the peace sign, keeping the distance quite small between the fingers. The person is going to interpret that information as having one finger on their back, compared to if you placed those two same fingers on the back of the dorsal side of the hand, they would interpret that as two separate fingers. Because of the size of the receptive field, it changes how the information that we get. So if I have many receptive fields, then I will interpret information, I'll be more sensitive to the information that I am receiving. Versus if I have few receptive fields like the back, then I would not be able to differentiate some of those finer details. And so that's kind of just a little fun thing to take note of is that they perceive and interpret information differently depending on where we are. So again, the idea is that we have sensation, right? The idea of information from our environment being sent to our central nervous system, that is sensation. Now, what we do with that information, that is perception. You and I may perceive something, we may experience the same thing, but because of our backgrounds or um, our the knowledge that we have, we may perceive that information differently. And so this is more having to do with how you interpret that information. and then what you do with it. We should take note too that our sensory uh, mechanisms are very adaptable. So they, um, with constant stimulation, continuous stimulation, they become so adaptive that they their sensitivity becomes reduced. That is the idea of adaptation, that we encounter stimulation so frequently that in fact we our sensitivity to it goes down. So our general senses, when we talk about general senses, we are talking about things like temperature, things like pain and touch, pressure, vibration. One of the big words that you're going to want to take away is proprioception. This is the idea of our body position. Where are we in space? This is all part of our general senses. When we talk about special senses, which again, I've kind of separated out, our general senses or our special senses are olfactory, gustatory, visual, audio, things that that you would attribute to those senses you learned about when you were in pre-K and in kindergarten. Oh, I can see things, I can smell things, I can taste things, right? So, in addition to our olfactory, gustatory, vision, auditory, we have equilibrium. Equilibrium is going to be controlled in an area of the ear, and we'll talk about that when we talk about the auditory and um, equilibrium mechanisms of the ear. So that, in general, is our breakdown of sensory, sensation, perception, adaption, the idea that I could be almost overstimulated and then not react to things very well at all. And then the breakdown of what makes up our general senses compared to what makes up our special senses. When I first started in medicine, pain was something that we always asked our patients. But since my time in medicine, pain has ultimately become one of our vital signs that we need to be checking as we do our initial and reassessments. Of course, pain is subjective. We all interpret things different, as we have discussed, that we may perceive things differently even between one another. However, pain is something that is very real, has very physical manifestations, and is re is received and interpreted to the central nervous system in receptors that we call nociceptors. Nociceptors are our pain receptors. They are specifically our free nerve ending receptors. They are found in the skin, the superficial areas of the skin, in joints, in joint capsules, as well as the periosteum of the bone. When we talk about what is causing pain after a fracture, for example, that pain is really being caused by the periosteum, the free nerve endings that are innervating the periosteum. That's what's really causing the pain. Breaking of the bone itself does not have nerve endings, but the periosteum is innervated by free nerve endings. Free nerve endings are also in our blood vessel walls. In our deep tissues and visceral organs, we have very few nociceptors. And I want you to hold on to that. I want you to hold on to that information. We have very few in our deep tissues and visceral organs, very few nociceptors. So those free nerve endings. If we have those receptive fields that we talked about just a moment ago, and those receptive fields are large, that is going to be difficult for us to interpret where that pain is coming from. Again, think back. If I can put two fingers on someone's back and they interpret it as one finger compared to on the dorsal side of my hand when they can, I put two fingers on the dorsal side of their hand and they do identify two, that's having to do with the receptive fields, right? And if those receptive fields are large, as in many areas of the body, especially the visceral organs and those deep tissues, that makes it really hard to differentiate where that pain is coming from. So it makes our job a little bit more challenging. So some features of the nociceptors, they are sensitive to extreme heat or cold. So extreme temperatures, either way. They um, are sensitive to damage, mechanical damage, or chemicals, dissolved chemicals. Any of these may attribute to nociceptors their stimulation and excitability. So a very if I have a very deep cut, or I have encountered high heat, let's say I've touched the hot stove, or I have come into contact with caustic chemicals, then I am going to describe that pain as burning. And that is because these are strong stimulus to our nociceptors. So I came in contact with, for example, damage. So that deep cut, physical damage, mechanical damage, that high temperature, that high heat. I could go the other way. I could say that I was so cold that frostbite took over, right? Or a caustic chemical, I came into contact and I received like a chemical burn. I would describe that as a burning sensation. There are two ways that pain is communicated back to the central nervous system. It is through myelinated or unmyelinated fibers. And myelinated fibers are those fibers that are wrapped around with that sheath and expedites the traveling of the information back to the central nervous system, compared to unmyelinated, where it is not covered in those nice fatty sheaths, and that information, while still traveling quickly, travels slower than myelinated. This is important because myelinated pain is going to be described differently than unmyelinated pain. And so, myelinated fibers in the sensory division of our body, those are known as fast pain. So, that I'm going to describe to you how the book says that fast pain may be described. And I want you to kind of go, does that make sense or not? So, fast pain, myelinated fibers, right? So, we're moving quickly and typically is described as pickly, like your fingers when you sleep on your arm and you get those needle sensations in your fingers, that pickly feeling. Slow pain is your unmyelinated fibers. They are slower to travel to the central nervous system by comparison, and they are described as a burning or aching pain. Aching sort of makes sense, right? Because if I'm sort of slow and slowly getting there, it's pretty achy. I could see that. The burning, also think about if you had put your hand on a hot stove, for example, that burn sensation, that lasts a really long time. So that's how I sort of separate out fast pain versus slow pain and the descriptions of either, right? Slow pain is going to be difficult um to identify. Think of a stomach ache. Can you really pinpoint specifically where in the stomach it's hurting? Generally not. You can give a general location, but to say that it's specific to the epigastric, to the pyloric, very, very specific, and generally we're not able to do that. We're able to just say, I have a stomach ache. Recall that our visceral organs leading into this are not innervated very well with free nerve endings or our nociceptors. And so identifying visceral pain is a challenge. Our organs, for example, are innervated in our spinal nerves at different levels. It's not a direct communication to the central nervous system. For example, my heart. My heart in general has very few nociceptors, very few free nerve endings to communicate pain specifically. However, the innervation that I do have is coming from nerves from around the rib cage, and those nerves are going to converge back to the spinal column through spinal nerves at different levels of the spinal cord. It's because of the converting that I'm getting information from not just my heart, but I'm also getting information from those nerves that are innervating my chest wall cavity, as well as other areas of the that those nerves are innervating, and they all converge into one spinal nerve. But that spinal nerve is getting information from multiple different areas. So, can I pinpoint exactly where in my heart I'm experiencing this pain? Generally, no. And because the nerves are being converged into one spinal nerve, I may in fact interpret that heart pain as, say, pain in my left shoulder, because the nerves that innervate my left shoulder converge with that same spinal nerve that my heart is converging with. So I may interpret it as something different. This is where referred pain comes in. Referred pain is I am experiencing pain, but I feel it in a different location than where it's actually coming from. That is really important to know. On page 346, there are some examples of referred pain. For example, on this slide, we're talking about the liver and gallbladder. I have pain in my gallbladder, and I perceive that I also have pain in my right shoulder. Pain in my right shoulder, but I haven't had any trauma. I haven't slept on it wrong. I would have no reason to have pain in my shoulder, but I feel it. I feel it. This is an opportunity for you to use your information, your foundation, and understanding referred pain and go ahead and deduce that, right shoulder pain may in fact mean that there's actually something going on with the liver or the gallbladder. Continuing referred pain, again, I started to talk with you about the heart. The heart, the nerves that innervate the heart, those few that do, are also part of the same spinal nerve that innervates the left side of the neck, the left shoulder, the left arm. So, if I'm experiencing pain in these areas and I haven't had any trauma and I haven't had, there's no reason that I would have pain in these areas, I may be able to deduce that perhaps this is actually a heart problem. So, understanding where referred pain is typically how it's typically connected to our different visceral organs is very important in trying to identify your differential diagnosis and therefore your treatment for your patient. So continuing, there are different areas for referred pain that you might kind of put in the back of your mind to tease out when you are assessing your patients. For example, epigastric pain right under that xiphoid, just that epigastric, right kind of at that diaphragm area, may be a sign that there is something going on with the stomach, which is actually more lateral on that left side. So, again, referred pain may just help you differentiate different conditions, different differentials as you are trying to establish the right treatment and plan for your patient. When it comes to kidney or ureter pain, this image here is a great representation of what your patients may start to describe to you. They may describe pain as something in their pelvis on one side of the other that radiates down to the groin. This may hopefully trigger your memory to recall that, again, visceral organs such as the kidney and ureters, those deep organs, those visceral organs, they're not innervated very well. And so that information is going to be perceived as coming from somewhere different. And in this image, that pain is coming from the ureters, is actually perceived as coming from the pelvis, though, and traveling down the groin. And that should alert you to, perhaps there is something going on with the renal system, either a kidney stone in the kidney or a kidney stone in the ureter trying to exit, something going on there. Again, so hopefully this will just trigger some kind of recall for you when you get that patient that's is describing some pelvic pain that's coming around and going down to the groin area. Before we move to the next slide, I'm going to take the opportunity to discuss the thermoreceptors of the body. Thermoreceptors are just that, using just the terminology to break it down. They are receiving information on temperature. And these are free nerve endings that are in the dermis, in the skeletal muscle, in the liver, and in the hypothalamus. Remember, the hypothalamus is going to manage many things and is the connection between the nervous system and the endocrine system. And I just think that this is a really fun trivia fact, is that there are 3 to 4 more cold receptors than there are warm receptors in the body. So 3 to 4 times more cold receptors than there are warm receptors. And there are no structural differences between these receptors. However, there are just more receptors that interpret cold than there are those that interpret warm. The other thing that I'm going to bring up is the mechanoreceptors. Mechanoreceptors, I want you to think about stretch mechanoreceptors or compressing or twisting, some kind of I'm mechanically manipulating the receptor. And there are 3 types of mechanoreceptors the book mentions: the tactile, which is your touch, the tactile touch, baroreceptors having to do with pressure, and proprioceptors, which are having to do with position. Now, as far as the intricacies in the tactile receptors, I'm not going to dive in all that deep into the weeds with the tactile receptors. Tactile receptors, what I want you to know is that there are different tactile receptors that are interpreting things like touch, pressure, vibration, and this is helping us to interact with the outside world. Apart from the idea of the sensations tactile receptors are going to communicate with for us, we don't need to know the 6 different types of tactile receptors found in the skin, for example. They're not going to change how you uh, manage your patient care. I just want you to know that these receptors differ and they help us interpret things like touch and pressure and pain and temperature and vibration. And that's all that I need you to take away from that information. When we talk about baroreceptors, we do need to recall that we have the baroreceptors in the carotid sinus, so in the carotid area here on either side, and then in the aortic sinuses. So at that aortic arch area, we have baroreceptors that are doing what? Paying attention to pressure. We have baroreceptors in the lung. They are paying attention to our respiratory rate and the rhythm. We have baroreceptors in the digestive tract. They are paying attention to movement. And again, we're talking baroreceptors having to do with stretch or compression, right? Or twisting. So these baroreceptors are making some sense, hopefully, to you. Baroreceptors of the colon, again, triggering the defecation reflex. Very important. Baroreceptors of the bladder wall, triggering the urinary reflex. When we talk about proprioreceptors are helping us to identify where we are in space. So the areas that we will have these types of receptors are going to be in our joints, in the ability to understand the tension of the tendons and the ligaments, for example, and understanding muscle contraction, where we are in space, right? They are going to trigger stretch reflexes. So I don't overstretch. And we know that reflexes are going right to the spinal cord and are interpreted by the spinal cord, in which information is sent directly back to the area. And then later, the brain is brought up to speed on what has transpired. The next type of receptor we're going to talk about are the chemoreceptors. The chemoreceptors are paying attention to the chemistry, the oxygen, the pH, which is our hydrogen concentration, our carbon dioxide concentration. So, specifically, we've got a couple of areas where we need to recall where we're going to have our chemoreceptors. First thing, we're going to have our chemoreceptors that are in the respiratory center of the medulla oblongata. That area specifically is paying attention to the cerebral spinal fluid. In paying attention to the cerebral spinal fluid, these chemoreceptors pay attention to pH and carbon dioxide. Take note, it is not paying attention to oxygen. So, again, in the medulla oblongata, when we are looking at the cerebral spinal fluid, the respiratory center is paying attention to pH, which is our hydrogen concentration, and our carbon dioxide only. When we get to the chemoreceptors of the carotid bodies and the aortic bodies, we're paying attention to pH, carbon dioxide, and oxygen. So in our carotid bodies and our aortic bodies, this is where we are paying attention to oxygen and sending that information back to the brain through the cranial nerve 9, and cranial nerve 10. So these are the areas that are paying attention to oxygen. And also take note that the carotid bodies and aortic bodies are paying attention to these chemicals in blood. Okay. So next we're going to move on to one of our first special sensory organs, and that is olfactory. Olfactory, here we're talking about our sense of smell. There is a pathway for olfactory, and one of the things I want you to recall is that cranial nerve number 1 is our olfactory nerve. And we are going to talk about how information is brought into the olfactory system and then turned from a chemical process into a neurological, electrical component. And how that is done, if we look at this image here, we have a rose that we are enjoying the sweet smell of this rose. The chemical components that make up that fragrance are going to enter into the nasal cavity, and they're going to travel until they land in the olfactory epithelium. Olfactory epithelium. And if we take a snapshot of that olfactory epithelium and we move over here to this right side of this slide, you see here at a microscopic anatomical level, we've got the fragrance of that rose being a chemical compound that is going to get trapped in the olfactory epithelium. Within the epithelium, we have the olfactory dendrites. Dendrites, where we start our communication with a neuron, right? So these dendrites are integrated all along the olfactory epithelium, and they are going to go ahead and capture, with this mucous membrane here, they're going to capture these chemical components. These chemical components are going to they're going to trigger the dendrites to signal different information, depending on what the fragrance is, up through the olfactory receptor cell. So the dendrite is going to send that information up into the olfactory receptive cell. And that information, again, we're converging. So we've got several of these olfactory receptor cells that converge into a bundle, into a nerve fiber that enters in to the cribriform plate of the cranial vault. The cribriform plate, if you look back over on this left hand side here, you'll notice that there are olfactory nerves that innervate through the cranial vault into the superior side of the nasal cavity. And that is a very small um, group of grouping of, I guess you'd say, entryways or pathways through this bony structure where nerves are literally coming from our cranial nerve number one, our olfactory nerve, into our nasal cavity. So again, we've got the chemical substance getting trapped into the olfactory epithelium, the mucus area of the olfactory epithelium. Within the olfactory epithelium, we have the dendrites that are going to interpret the chemical information into electrical information, depending on what it is. We're going to converge into a olfactory receptor cell. We have many olfactory receptor cells that converge again through or come together, they converge together to become an olfactory nerve. Olfactory nerve number one, the fibers of olfactory nerve number one through the cribriform plate of the cranial vault, and they land in the olfactory bulb. From the olfactory bulb, they travel through the olfactory tract to the central nervous system to the area of olfactory, which, if you recall back to our nervous our nervous discussion, this is going to be in that insulet between the when we look at the temporal lobe and the frontal lobe. There is, if we pull those lobes apart, that insulet is in there, and that is where we have olfactory um, uh, being interpreted by the brain. And that is what we're going to discuss on the olfactory portion of the special senses. Next, we're going to discuss gustation, or the sense of taste. So, the sense of taste, here we are going to have a variety of different taste receptors. Gustatory receptors is another more formal term. And these are what we consider our taste buds. These are specialized epithelial cells that are interpreting the sensation of taste, whether it's food, drink, etc. And they are scattered throughout the tongue and the pharynx and larynx as well. So, as far as the specific names of each of the taste buds, we're not going to dive that in depth. There are taste buds here at the side, on the lateral sides of the tongue, that differ from the taste buds on the surface, anterior surface of the tongue, compared to the more posterior side of the tongue, this V-like structure. And then, of course, then there are taste buds on the most posterior side, as well as the pharynx and larynx. And we're not going to get into what are they called and how are they different, etc. What we are going to talk about is the primary taste sensations, and they are listed here on on the tongue as sweet, salty, bitter, and sour. There is an additional two senses that are not listed here on the tongue that you should familiarize yourself. And the two are umami and water. So umami is the sense of, I think of steak when I think of this. I think of that uh the text says pleasurable, but that flavor of a really nicely prepared steak is just umami. Okay. They reference beef broth, chicken broth, parmesan cheese as some other um examples. When it comes to water, everyone, not everyone, but most people will say water doesn't have a taste. In fact, we do have receptors that are specific only to water, and those are water receptors. And they help send information to the hypothalamus to regulate water balance in the body. So we do have receptors in the oral pharynx that are communicating to the hypothalamus the level of water, etc. We are going to just touch on the fact that the information from our taste buds are going to be communicated back to the central nervous system through three cranial nerves, the facial nerve or cranial nerve 7, the glossopharyngeal nerve, which is cranial nerve number 9, and the vagus nerve, cranial nerve number 10. This information is going to be sent through the afferent fibers back to the central nervous system, specifically to the medulla oblongata, where it is going to send further information into the the thalamus and into the gustatory cortex. Again, that's that area that's in that insulet between the frontal lobe and the temporal lobe. And if we pull that apart just a little bit, in that insulet, there's that gustatory cortex that's interpreting our our sensations. Now, I do want to just note here that when you are unable to smell, your olfactory is, let's say you've got a cold, and what have you, and you lost your sense of smell, it will affect your ability to taste. So the two um are they collaborate, right? They collaborate. So without being able to smell, you are inhibited in what you're able to interpret as far as taste goes. Typically when you're sick, maybe things taste a little bit more dull. They're not as scrumptious as they are when you're not sick, or you lose them at all in completely, like when we had COVID, for example, where we just left them entirely or would lose them entirely. So the two are connected, and we do need smell in order to have the sensation of taste, the uh, to interpret taste. And that is going to conclude this section of chapter 9. We're going to go ahead and talk about the next couple of sensory um, special senses in a separate presentation.